Good evening everyone. Today's topic of discussion is the venous thromboembolism in cancer patients. I am Dr. Dwideep from SCG Bangalore. I will be discussing about the pathogenesis, risk assessment, guidelines and the practice points. So why should we bother about the venous thromboembolism? The association between the cancer and the thrombosis has been recognized for more than 150 years, and the cancer patient experiences 2 to 20-fold higher risk of developing venous thromboembolism than the non-cancer patients. The venous thromboembolism was found to be a leading cause of mortality in cancer patients. The annual average total cost for the cancer patient in VTE was found to be almost 50% higher than that of the cancer patient without VTE. So this graph shows you the risk of developing venous thromboembolism in a single cancer patient compared to the general population. You can see over here like that after the diagnosis the graph goes to a peak where the patient has maximum risk of developing venous thromboembolism while admitted in a hospital, undergoing biopsy or surgery and the central venous catheter insertion, and afterwards the risk comes down again and again goes up during the palliative care stage. So a little bit about the history of venous thromboembolism. This picture is Professor Arnold Trosso. He is the first to associate thrombosis and malignancy, and the combination of the two conditions is still often called Trosso syndrome. He suggested screening for malignancy in recurrent or idiopathic thromboembolic disease. He proposed that the pathology was not mechanical obstruction but a change in the character of the coagulation system itself. He is the first to suggest that the association may be integral to the cancer growth itself. So what are the clinical tests telling us? This graph shows the absolute rate of venous thrombosis for an individual calendar year compared to those of the age-matched non-cancer patient. You can see that these dotted lines shows the age-matched non-cancer patients, whereas for a cancer patient the risk goes high from the time of diagnosis to the time of metastasis. So why cancer patients are at risk of venous thromboembolism? So there is multiple mechanism by which a malignant cell can cause venous thromboembolism. The malignant cell can activate the monocytes and macrophages, which in turn releases the tissue factor. And second mechanism is stimulate the release of the mucin salicylic acid, which has a procoagulant activity. And this chemotherapy is an independent risk factor for venous thromboembolism, whereas this chemotherapy can directly cause endothelial disruption. Also it can release interleukin and interleukin 6 and tumor necrosis factor from inflammatory cells. All these will converge into a final common pathway which will activate the factor 12 into the factor 12A, which finally result in the fibrin clot. So this chart shows the presumed pathomechanism of anti-cancer agents causing venous thromboembolism. The fluorinated compounds causes vasospasm, arterial and venous thrombosis, whereas cisplatin causes endothelial damage, Raynaud phenomenon and thrombosis. L-asparginase, tamoxifen, dexamethasone, erythropoietin stimulating agents all alter the plasma levels of coagulation factors. The thalidomide group of agents will cause endothelial damage, alter the plasma levels of factor 8 and von Willebrand factors. So what are we dealing with? There are patient related factors which increases the risk of venous thromboembolism, such as old age, obesity, other comorbidities, previous history of venous thromboembolism, female sex, black ethnic origin and thrombophilia. There are cancer related factors like a cancer site, the histological type, the metastatic status of the disease, early treatment after the cancer diagnosis. Coming to the cancer types, there are pancreas, brain, liver, lung and ovarian cancer has a high risk compared to the colon cancer, which has 0.8% of risk, and the prostate and breast cancer, which has 0.9% of risk. Coming to the risk of venous thromboembolism after the cancer diagnosis, you can see from this chart that in any type of cancer, the local stage and comparing that with the remote stage, that is the metastatic stage, in the metastatic stage we have a 5-fold increase in risk of venous thromboembolism compared to the local stage of the disease. There are treatment related factors like the recent surgery, hospitalization, central venous catheter insertion, chemotherapy, hormone therapy, and anti-angiogenic agents and erythropoietin administration all increases the risk of venous thromboembolism. There are biomarkers investigated to identify the patient at a high or low risk of venous thromboembolism. Of this, the soluble P-selectin and the D-dimer has come up recently. The clinical trials and observation shows that the high plasma levels of soluble P-selectin is an independent predictor of venous thromboembolism in cancer patients. These are the list of the cancers which increase the levels of P-selectin. There are different scoring systems to assess the risk in a cancer patient. The first one is a modified Corona score, which is recommended by the ASCO. It is a 5-point scale which sees the cancer type, the pre-chemotherapy platelet level, the hemoglobin level, and the leukocyte count, and the BMI of the patient. When the score is 3 or more, the patient is at high risk of developing VTE. 1 or 2 points translate to intermediate risk, and the patient is having low risk when the patient has 0 total points. This is a next scoring system, the Vienna CAT score, which incorporated the soluble P-selectin level and D-dimer in addition to previously described factors. This Ottawa scoring system incorporated breast cancer and TNM stage 1 as negative factors, which reduces the risk of venous thromboembolism. The -3 to 0 point translate into low VTE recurrence, and 1 to 3 points high VTE recurrence. So comparing this scoring system, the Corona score has a positive predictive value of 17.7% when the score is more than 3. Whereas the Vienna CAT score has a higher positive predictive value of 35% when the score is more than or equal to. That translates to the high predictive value of the soluble P-selectin and the D-dimer. So we'll skip through the guidelines. We'll see what are the guidelines regarding this. The NCCN guidelines and the ASCO guidelines all recommend the use of prophylactic anticoagulation therapy in a surgical patient. This include the pharmacological therapy as well as intermittent pneumatic venous compression devices or plus or minus the graduated compression stockings. The ISTH guideline shows that the pharmacological prophylaxis should be started in the preoperative period and extended into the postoperative period. It also suggests that the use of the highest prophylactic dose of low molecular weight heparin is needed to prevent the postoperative venous thromboembolism. The ACCP guidelines also implies the importance of venous thromboembolism prophylaxis in cancer surgical patients. So what about the treatment of established venous thromboembolism? All the guidelines have opined that the low molecular weight heparin is recommended for the initial treatment of established venous thromboembolism in cancer patients, as well as the treatment of the cancer-related venous thromboembolism with the fondaparinux and other newer oral anticoagulant agent is very much limited. Coming to the dosing regimes and prophylaxis, for the prophylaxis and treatment of venous thromboembolism, for the surgical patient, what we follow here is unfractionated heparin, dalteparin, enoxaparin, and fondaparinux. That's the same as the guidelines. And the 5,000 units 2 to 4 hours preoperatively and once every 8th hourly subcutaneously thereafter can be given. And for the enoxaparin, 20 mg 2 to 4 hours preoperatively and 40 mg once daily thereafter can be administered for the prophylaxis. So when to start with the anticoagulation? What NCCN guidelines telling is that we should stratify the bleeding risk in a cancer patient undergoing the surgery. That is means the neurosurgical procedures, prostatectomy, the cardiac valve replacement, and another coronary artery bypass grafting has a very high risk of bleeding in the postoperative period. For those kind of surgeries, we can initiate the prophylactic dose at 24 hours and consider the therapeutic dose of anticoagulation only at 72 hours. When the bleeding risk is high, that is as in a major any other cancer surgeries, reconstructive plastic surgeries, renal or hepatic biopsy, in such cases we can start with the anticoagulation prophylaxis at 12 to 24 hours. So when a patient on anticoagulation coming for surgery, what is the plan of action? When the cancer patients on anticoagulant recurring surgery coming for an emergency surgery, what is suggested is the reversal of the anticoagulation, proceed with the surgery, and post-operative anticoagulation based on the bleeding risk. We can consider the IVC filter if venous thromboembolism has occurred within 1 month of the surgery. For non-emergent surgery, we should assess the bleeding risk and categorize them into very low bleeding risk and others like low, moderate, high or very high bleeding risk. If the patient the surgery belongs to the very low bleeding risk group, we can continue with the anticoagulation and proceed with the surgery. In the other group, we should go ahead with the perioperative thromboembolism risk assessment. So coming to the perioperative thromboembolism risk assessment, what the guideline says is that we can consider the IVC filter if the VTE has occurred within 1 month of surgery, and when the perioperative thromboembolism risk is low, we can stop the anticoagulation without a bridging therapy. When the thromboembolism risk is moderate, we can stop anticoagulation but should consider the bridging therapy. And when the thromboembolism risk is high, we can stop anticoagulation and but only with the bridging therapy, and we should proceed with the surgery followed by postoperative anticoagulation based on the bleeding risk as mentioned above. So coming to the therapeutic anticoagulation failure in cancer patient, when the patient is on warfarin, we can check the INR. If the INR is in the therapeutic range, we can switch over to low molecular weight heparin or unfractionated heparin. When the INR is in subtherapeutic range, we should increase the risk of warfarin dose and treat with treat with the low molecular weight heparin as a bridging therapy. When the patient is on unfractionated heparin, we should check the APTT levels. When the APTT levels is in the therapeutic range, we can increase the dose of unfractionated heparin. We can switch over to low molecular weight heparin. We can also consider the placement of IVC filter. If the APT levels is in the subtherapeutic range, we can increase the unfractionated heparin to reach the therapeutic range. When the patient is on low molecular weight heparin, what we should see is the anti-10A levels, and we should schedule the dose more frequently, like a 12-hour dosage, or we can increase the dosage of the low molecular weight heparin. We can also consider switching over to fondaparinase and consider the placement of IVC filter. When the patient is on fondaparinase, we should again switch over to low molecular weight heparin or increase the doses of the same. So when there is a cancer patient with a thrombocytopenia and there is an event of venous thromboembolism occurred, what is the plan of management? Whenever this VT event is an acute one, we should check the platelet count. If the platelet count is more than 50,000, we should proceed with the weight-based full dose of low molecular weight heparin. Whereas whenever the platelet count is less than 50,000, we can transfuse platelet and try to maintain the platelet count of more than 50,000. Then again give the full dose of low molecular weight heparin. Whenever we are unable to maintain the platelet count of more than 50,000, and the platelet count is less than 20,000, we can hold the anticoagulation. If it is between 20,000 and 50,000, we can give half dose of low molecular weight heparin. So coming to whenever there is a subacute or chronic venous thromboembolism event, the flowchart is the same except that we are not transfusing the platelet to maintain the platelet count of more than 50,000. So what to do with a recurrent VTE in cancer patient? Whenever there is a recurrent VTE occurring during anticoagulation therapy in a cancer patient, we should probably exclude HIT and non-compliance with the treatment. So once this is excluded, we should see the therapeutic range of the anticoagulation. When there is a subtherapeutic anticoagulation in the patient, when the patient is receiving warfarin, we can bridge with the low molecular weight heparin and increase the warfarin dosage to the target of 2 to 3. When the patient is already on low molecular weight heparin, we can switch to the full dose of low molecular weight heparin. And when the patient's levels are in the therapeutic anticoagulation range, we can and the patient is on warfarin, we can shift it to the full dose of low molecular weight heparin. And if the patient is already on low molecular weight heparin, we can increase the dosage by 20 to 25% and reassess the patient in 1 week. If there is a symptomatic improvement, we can continue with the current management. If there is no improvement, we can see the peak anti-10A levels and adjust the low molecular weight heparin accordingly. So where do we need to improve in the treatment of venous thromboembolism? The awareness is the key. The future iteration of comprehensive clinical guidelines should be addressed the role of newer oral anticoagulant agent for the treatment of venous thromboembolism in cancer patients. Greater awareness of the oncologist is needed to increase the use of prophylaxis for venous thromboembolism in hospitalized patients with cancer. So what are the practice point and take home message? So should the hospitalized patient with cancer receive an anticoagulation for venous thromboembolism prophylaxis? The answer is a big yes. The hospitalized patient with cancer should be considered candidate for the venous thromboembolism prophylaxis with anticoagulant in the absence of bleeding or other contraindication to anticoagulation. The second question is, should ambulatory patient with cancer receive anticoagulation for venous thromboembolism prophylaxis during the chemotherapy? The answer is routine prophylaxis with an antithrombotic agent is not recommended, and the patient receiving thalidomide group of drugs or dexamethasone are at a high risk of thrombosis as seen in the previous slides, and that warrant prophylaxis. So we can go ahead with low molecular weight heparin or adjusted dose of warfarin in such patients. So should the patient with the cancer undergoing surgery receive perioperative venous thromboembolism prophylaxis? For the patients undergoing major surgical intervention for malignant disease, they should be a candidate for thromboembolism prophylaxis, and such patients include patients undergoing laparotomy, laparoscopy or any thoracotomy procedure lasting greater than 30 minutes should receive the pharmacological thromboprophylaxis, and the prophylaxis should be commenced pre-operatively or as early as possible in the post-operative period. So what is the ideal perioperative prophylaxis? The mechanical method should be added to the pharmacological method but should not be used as a monotherapy for venous thromboembolism prevention unless the pharmacological methods are contraindicated because of active bleeding. A combined regime of pharmacological and mechanical prophylaxis may improve the efficiency, especially in the highest risk patients. The prophylaxis should be continued for at least 7 to 10 days post-operatively. The prolonged prophylaxis for up to 4 weeks may be considered in patients undergoing major abdominal or pelvic surgery for cancer with high-risk features such as residual malignancy after operation, obese patients, and those with a previous history of venous thromboembolism. So what is the best treatment for a patient with cancer with an established venous thromboembolism to prevent the recurrent venous thromboembolism? All the guidelines suggest that low molecular weight heparin is preferred approach for the initial therapy. Even up to 6 months, low molecular weight heparin is recommended. The warfarin with a targeted INR of 2 to 3 are acceptable for long-term therapy when the low molecular weight heparin is not available. After 6 months, indefinite anticoagulation therapy should be considered for special patients with active cancer such as metastatic disease and those who are receiving continued chemotherapy. So what is the best treatment for a patient with cancer with established VTE to prevent recurrent VTE? So as well as we can consider the insertion of vena cava filter in patients with a contraindication to anticoagulation therapy and those with recurrent VTE despite adequate anticoagulation. For elderly patient, the anticoagulation recommended for established VTE as described with any other patient with cancer. So should the patient with the cancer receive anticoagulants in the absence of an established VTE to improve the survival? The anticoagulants are not recommended for improving survival, not for improving the survival in cancer patients. And so how long do we need to continue VTE prophylaxis, and what is the preferred agent? Again, the low molecular weight heparin is preferred over warfarin for the early maintenance it should be continued for a minimum of 3 months. After 3 to 6 months, based on the individual evaluation, risk-benefit ratio, tolerability of the patient preference and the cancer activity, it may be switched over to warfarin. In the event of VTE recurrence, what is next? The plan of action is to switch from warfarin to low molecular weight heparin. When the patient is treated with warfarin, we can increase the dose of low molecular weight heparin, and we can consider the insertion of vena cava filter if the patient is still having recurrence with adequate anticoagulation treatment. So what is the role of newer anticoagulant agent for the treatment of VTE in cancer patients? The answer is not known until now. We have limited data available, and further scientific data in cancer patients are needed before this agent could be recommended for prophylaxis or treatment of VTE in the special population. So these are my references. Thank you very much for watching. Thank you.